Happy Sunday, everybody. Thank you all for having me. I'm very excited to be a part of this group. Thank you to Hannah and Dakota for asking me. My name is Tyler Nolan. I am a family medicine PGY2 resident at the Cleveland Clinic. I went to the American University of Antigua for medical school, and so I love Caribbean students. I feel like Caribbean students have something special, and everybody I speak to, um, that closely works with Caribbean students in residency and whatnot all think similarly in that there's something special and more. I don't know. I feel like we get different type of training than traditional students might. So I'm very excited for all of you to continue your journey into medicine and see where it takes you.
Thank you.
Okay. Hi, everybody. I know a big chunk of you guys here, but for those who I haven't met, my name is Hannah. I am a fourth year at Ross University. And today I will be talking a little bit about hair loss and diagnosis and treatment. So hair loss is really commonly seen and it has a bunch of different causes, which is why I thought that this would be a really good talk for today. In almost every single rotation that I have gone through, I have seen at least one patient with hair loss in one aspect or another. So although I got this from the AFP, but I do think that this is really a generalized topic. So anyway, like I was saying, hair loss is really common and it has a lot of different causes. The causes can be emotional, physiological, metabolic. It can be due to chemotherapy and a bunch of other reasons. Therefore, being able to systematically gather a history and examine your patient and determine a cause is really, really beneficial to reaching a diagnosis. As I was saying, the American Family Physician published this article in September of, oh, I have cats, sorry. They love when I'm on meetings, so if I'm batting things away, sorry. They published this article in September of 2024. And basically, an overview of this is that it just goes through a bunch of different types of hair loss, pertinent history that you should be taking to gather your diagnosis, a pertinent physical exam, as well as and to determine your diagnosis, as well as other treatment options. So for a little bit of background, more than 80 million people in the US are affected by hair loss, and there's an estimated $8.2 billion that are spent on hair loss globally. So this is a pretty big patient problem. Patients also tend to be very upset when it comes to their hair loss. Hair loss is often accompanied by anxiety, depression, and a lower quality of life, especially more Western beauty standards are really, really central around hair. So this affects patients, I think, more than one would initially think. There are two types of hair follicles. You have terminal hair follicles, and those grow like thick, long hair. And then you have your vellus follicles that produce short, fine, non-pigmented hair. As you age, the type of hair that you have changes. At birth, the scalp has terminal follicles, and the rest of the body has more vellus hair. And then during puberty, there's an increase in androgens, and that causes a switch to terminal follicles on the chest, axilla, and the genital area. And then there are three phases of the follicular cycle. The anagen phase is the growth phase that lasts for about 2 to 6 years, and this is more the hair on your head. The catagen phase is the involution phase, or the phase between anagen and telogen. And this makes up about 1% of the hair on your scalp. And then telogen is the resting phase, and this makes up about 5 to 10% of the hair on your scalp. Once the telogen phase is complete, hair is eventually shed. Each follicle has its own cycle, and that makes the telogen phase less apparent. So you're not just losing all of your hair at once. They all have their own unique cycle. But on a normal day, you lose about 100 hairs. Alopecia itself has three different characterizations. It can be diffuse, it can be patterned, or it could be focal. Diffuse alopecia is caused by telogen or anagen effluvium. Telogen effluvium is when hair enters the resting phase prematurely, leading to shedding after a stressor. Anagen effluvium is when there's actively growing hairs that are damaged, causing a sudden widespread hair loss. And then there's patterned alopecia. This is the most common example. Oh, excuse me. There's patterned alopecia, and then there's androgenic alopecia, which is the most common example. Focal alopecia is consisted of alopecia areata, tinea capitis, traction alopecia, and this is when hair loss is defined to a focal area. Most cases of alopecia are not scarring, which is actually really good. It's a lot easier to treat. Scarring alopecia should be referred to a dermatologist because this is really hard to handle. A lot of times you probably won't get hair growth back, so it's best to send to a specialist in this case. Taking a history on your patient's hair loss is really crucial. You want to ask, is the hair being shed in large clumps? Was there physical or emotional stress in the patient's life recently? Have they undergone chemotherapy? Have they been using tight hairstyles? You want to look for any sort of underlying thyroid disease or malnutrition, or if there's a sort of family history. The distribution and appearance of hair loss will help lead you to the correct path of your differentials. So what you're looking for here is it smooth, round lesions with hair shafts that thin towards the scalp? It could be scaly, erythematous lesions with occipital adenopathy. You could have bitemporal thinning, including the vertex of the head, irregularly shaped patches of hair loss with hair broken at different lengths, with new hair growth, and it can also be seen on the eyebrows and eyelashes. All of these are little tidbits to help you go through your differentials. And one thing that you can do is what's called a hair pull test. And that's what this picture is demonstrating. So the hair pull test, you grasp about 1 to 2 centimeters of hair between your thumb and your index finger and your middle finger. And you really, really gently pull and apply traction while sliding the fingers distally down the hair shaft. And then broken hair is discarded. But a positive test is when there's 2 or more hairs that are removed, but the follicle is still attached at the bottom. So that's why broken hair is discarded, because that doesn't make a positive hair pull test. You want to actually look for the follicles that are at the bottom of the hair. Positive results in more than one are indicative of telogen or anagen effluvium. You can also do lab examinations. This helps to distinguish hairs that are in the telogen or anagen phase by if the root sheath is still attached. If it is still attached, then you would know that you're in the anagen phase. You can also do fungal scraping. Specifically, this is for tinea capitis. And then you can evaluate for underlying causes such as hypothyroidism, iron deficiency, liver disease, or syphilis, just to name a few examples. So the first type that we will dive into is anagen effluvium. This occurs within 2 weeks of administration of any sort of offending agent. In this case, it is usually chemotherapy. Hair growth often resumes after chemotherapy is discontinued. The toxin exposure causes damage to the hair shaft, leading to breakage and damage to the bulb of the hair follicle, causing hair loss. Oftentimes, patients undergoing chemotherapy will do scalp cooling. This helps preserve their hair. And the mechanism by which that kind of works is when you put a cold cap on, you have vasoconstriction, and that leads to less chemotherapy actually getting to the hair shafts and the hair follicles. So in theory, you would see less hair loss. It doesn't work for all patients, and it really is dependent on chemotherapy type, but it is a treatment option if you have the right candidate. Secondly, you have telogen effluvium. This is the most common cause of diffuse hair loss. The pathophys is not really completely understood, although it's thought that a stressor that advances follicles into the telogen phase is what causes it. Most stressors are severe illness, it could be childbirth, and major surgery. Evaluation should include, again, testing for iron deficiency, anemia, thyroid disease, malnutrition, vitamin D deficiency. These are all things that can lead you to go into the telogen effluvium phase. Medications also can sometimes cause this, and medications such as lithium, retinoids, starting or stopping OCPs. Telogen effluvium usually begins about 2 to 4 months after the inciting event. And this causes more distress to a patient because it kind of seems like it's out of nowhere since it is so long after the inciting event occurs. And it usually normalizes about 6 to 9 months later, as long as the event has been corrected. Third, you have androgenic alopecia, and this is the most common form of hair loss. It affects about 50% of male patients and 30% of female patients. The diagnosis really can just be made clinically since there's no other hair loss that looks much like this. You'll have bitemporal thinning of the frontal and vertex scalp with complete hair loss with some of the hair on the occiput and temporal fringes. Females have more diffuse thinning pattern of the vertex with sparing of the frontal hairline. In androgenic alopecia, the terminal follicles undergo a shortened anagen phase, and then they become shorter vellus follicles. This is due to the conversion of testosterone to DHT that binds to the androgen receptor that is actually on hair follicles. With that being said, patients with an increase in 5-alpha reductase activity and androgen receptor density or activity tend to have worse androgenic alopecia, and it really can be related to genetics. This is a benign condition, but cosmetics lead patients to search for treatment. So treatments for men can include topical minoxidil, and this prolongs the duration of the anagen phase, and it is an effective first-line treatment. The 5% solution has found to work better, specifically in men, when applied to the scalp and not just on the hair. You want to make sure you're actually hitting the skin on your scalp. Side effects really are just contact dermatitis. It's a fairly safe medication. Patients can also be put on 1 milligram of finasteride daily as a first-line therapy for males. And you often need to use this for about 1 year before you see any sort of changes. Adverse effects for finasteride include sexual dysfunction. And then for females, it's a little bit harder to treat, but females can be put on spironolactone or finasteride. And it can be added with minoxidil or used on its own, but evidence is really lacking for females for treatment for this. Next, we have alopecia areata. This is an immune-mediated process in which follicles in the anagen phase are prematurely transitioned into the catagen and telogen phase, leading to really rapid hair loss. Patients present as an acute, patchy hair loss with short vellus hairs, broken hairs, and what are called exclamation point hairs. Focal hair loss can occur anywhere on the body, and the spectrum of disease includes total hair loss of the scalp, which is called alopecia totalis, or the entire body, which is called alopecia universalis. Patients may undergo co-occurring nail disorders, including nail pitting. It can be associated with other autoimmune diseases, so you want to make sure that you're screening for other disorders that are clinically indicated. Alopecia areata spontaneously remits in most patients with a limited presentation, less than 50% of the scalp. Limited cases can be treated with intralesional corticosteroids every 4 to 6 weeks, although a recent review did not find evidence to support this treatment method. There is an oral immunosuppressant that increases growth over 75%, and topical corticosteroids can be used for treatment in children. Next, we have tinea capitis. This is a really common cause of hair loss in children. I know that you guys have seen hundreds of questions on this. It's a dermatophyte infection that causes itchy and scaling hair loss. The most common presentation is 1 or more slowly enlarging scaly patches. Broken hair follicles appear as small black dots in the area of hair loss. It is associated with lymphadenopathy, and it is a really typical finding. This also can have diffuse scale or a more subtle hair loss, which is an immune reaction where crusted plaques and draining pustules form. Diagnosis for this is also made clinically, but it can be assisted with fungal cultures or microscopic examination of the skin scrapings when using potassium hydroxide. Oral antifungals are first line for this. Topicals don't penetrate the skin enough. So griseofulvin and terbinafine are typically what's used, but azoles are an alternative treatment with less evidence backing their use. Next, the 3 that we have here The first one is traction alopecia, and this occurs when there's prolonged tension of the hair follicle. This is commonly caused by hairstyles or hair pulling. The initial manifestation is erythematous papules, which can progress to hair loss just from the irritation from the hair being pulled. Initial treatment is to discontinue or modify the style that's causing the traction. Minoxidil hasn't been shown to promote hair growth in these patients, so it's really best to just stop whatever the action is that's causing this. Trichohexis nodosa is when the hair is weakened by application of heat or chemicals, making it more susceptible to damage. Weakened hair shafts can break because of trauma, therefore leading to the appearance of thin, short, and brittle hair. This can also be due to errors in metabolism or systemic diseases. Presentation in infancy would be indicative of a more genetic disorder causing this, so workup should include a full lab panel to make sure that there are no underlying causes. The goal of treatment here is to correct any underlying problem and avoid any further hair trauma. Another cause of hair loss is trichotillomania, which we also get a bunch of questions on. This is a type of traction alopecia in which the patient repeatedly pulls out their own hair. This leads to hair loss and may cause significant distress to a patient. It is most common in children and adolescents and can be really difficult to diagnose, and patients usually aren't forthcoming with the fact that they have hair pulling. Patients may present with irregular patchy alopecia that may involve the scalp, but it also might involve other body sites, including eyebrows and eyelashes. The remainder of the hair on the patient is usually normal with a negative pull test. The base of the occiput tends to be spared because it's harder for patients to reach there, and it can be a little bit more tender. Here is where patient history is really important. It can be compared to the criteria in the DSM-5 specifically. There can be benefit from behavioral therapy here, but there's really insufficient evidence of what medication could be effective for patients who have trichotillomania. Here is just a chart going over pretty much everything I said. I wanted to throw this in there just in case I had said something that somebody wanted to re-reference. So this is almost everything that I have gone over so far. You are going to see some sort of hair loss in almost any specialty that you enter. So being able to use your history and physical examination skills to narrow down your differentials is really, really important. Like I initially had opened with, this is something that's really distressing to patients. So being able to come up with some sort of a diagnosis or some sort of a treatment plan that you think will work is really important when you have a patient who has hair loss. So to end out, I have a few clinical questions. So the first one, I have a 7-year-old boy is brought to the office by his mother because of a 1-week history of hair loss and a 1-month history of an enlarging itchy lesion on the scalp. He has no history of serious illness. His vaccinations are up to date. His physical examination shows the findings that are in the photograph below. Microscopic examination of a scraping of the lesion treated with KOH shows branching hyphae. Which of the following is the most appropriate initial pharmacotherapy for this patient? You can throw it in the chat or say it, whatever you guys are comfortable with.
B.
Yes. It is, I always get tripped up on this because it's really important to remember. I always just intuitively think that it would be topical. So remember that you wanting to give somebody oral terbinafine is huge. I get this question on every practice exam that I take. I think this has been on it was on step 1. I get a ton of step 2 questions on it. This is really important to know.
Yeah, with the hair and the nails, it has to be systemic medication.
Yes. The second question that I have is a little bit trickier. A 27-year-old female presents to the clinic due to hair loss. She states that small clumps of hair keep falling out when she showers or when she's brushing her hair. There is no pain or itching on the scalp. She recently had an uncomplicated vaginal delivery 3 months ago. She's currently not on any medications. Her thyroid levels are all within normal limits. What is your diagnosis here?
C.
Yes. This patient is going through telogen effluvium, and it is secondary to her giving birth 3 months ago. So like I said, it can be a little bit later than the event that took place. So she's probably really confused and scared and already stressed out with a newborn. But yes, she has telogen effluvium. That is all that I have. This is my reference for where I got the paper. Thank you guys for listening. And if there's any questions, feel free to shout them out.
That was a wonderful presentation on hair loss, Hannah. Thank you so much. Absolutely. I think you had a lot of great pearls. I don't know where you guys all are in terms of your journeys with like step 2, step 3. I would bet money you will get on step 2 if you haven't taken it already. Maybe not the picture of tinea capitis, but them describing tinea capitis and wanting you to go for an oral terbinafine or the griseofullovin. So please sear that into your memory because you will get that. You also might get a telogen effluvium question as well. So those were two great sample questions that you put up there. That's a very common condition that you're going to see. Usually, like you said, in most specialties, family medicine especially, which I'm biased, obviously, is the best specialty. But you will see some sort of hair loss regardless of what specialty you're in. And it's very distressing for people, right? And it really depends on your patient. So maybe you guys in clinic have already seen some types of patients that were, um, you know, had some hair loss or maybe not yet, but the patient and the demographic of that patient is going to play a really important role in how they're going to even approach you with this problem. Um, I see that somebody has their hand risen. So what's up?
Oh, I just had a question. When you were finished speaking, I was gonna ask the
No,
question.
no, we can just roll with it. So
No,
whatever.
I was wanting to inquire, because the article didn't really speak about hair transplants, and I wanted to know, when does hair transplant become an option, and do you know what types of alopecia patients are eligible for that particular health or cosmetic service?
Sure. Um, so this is kind of like a hot debated topic almost. Certain patients will go, and it really is boils down to actually like insurance, right? So welcome to the world of medicine now, that the dark side of medicine that no one really teaches you in medical school. But most of those procedures boil down to what insurance companies would call cosmetic. So they're not life-saving, they're not life-altering, while a lot of people would debate, hey, like you said, this is altering people's mental health, their anxiety, their depression. A lot of these procedures won't end up being covered. Which is why you see a lot of these like social media influencers, and you see the videos of the people on the planes to Turkey and all this other stuff. And it's because their insurance here in the United States won't cover it, meaning that the cost of those procedures tends to be $50 to $100,000, which is a crazy amount of money. Um, and so people will end up flying to Turkey, staying at a 4-star resort for a week, and then flying back, having the procedure done during that week, and it'd still be cheaper than them just having the procedure here in the United States. So that tends to be a barrier for people. There tends to be other different types of procedures that you can undergo that aren't as expensive as like a hair transplant. Um, and those still would fall under the cosmetic category where insurances tend to likely won't cover it. But it would be like plasma-rich injections, would be the corticosteroid injections. Patients would go get their blood taken out, usually done at a dermatologist's office, or some certified family medicine physicians can do it as well. Go draw their blood, centrifuge it down, separate the red blood cells in the buffy coat, and you get basically the rich plasma, and you freeze it, and then the patient comes in on a certain like weekly schedule, and you just do little injections of this platelet-rich plasma into the scalp, and it helps stimulate more, blood growth to the area. And then the theory behind it is it helps kind of bring nutrients to the area. Those tend to be a little bit cheaper for patients. So there's really not a good answer. Long story short, there's not a real good answer of, hey, when these patients are indicated for a procedure, because ultimately coverage is poor.
Thank you.
We have Adrian.
Hi, yeah. So I believe the article mentioned immunosuppressants, and I think it also mentioned like immunomodulators, like baricitinib, I think it mentioned as well. So my question is basically, wouldn't the like use cases for these kinds of immunosuppressants be pretty limited because the risk of taking an immunosuppressant, it kind of outweighs the benefit of growing your hair?
Yeah. So you hit the nail on the head with that one, right? So when are you going to find somebody that's going to be willing to like prescribe an immunosuppressant just for like hair loss? You're going to find a hard time trying to find a prescriber for that. And like you said, it's just the benefits don't outweigh the risks. That's just good evidence-based medicine. And sometimes you'll find patients that'll push you one way or the other, and that boils down to like the art of medicine versus like the science of medicine, right? Like, how do you want to practice? If you sit there and you say, I'm going to literally tell you every little thing, if we're going to do like an oral, an immunosuppressant of what could happen to you. And ultimately, as you as a physician, if you document a number one like that, like crazy, that you went through, all the risks, the patient is agreeable to it, maybe having them sign a consent form, then I mean, hey, ultimately patient autonomy, right? Like, then they can go down. But that should be the last resort. Like, my life is ruined. My girlfriend left me. My wife left me. My kids say, hey, dad, you look crazy without this hair. Like, my life is in shambles. Maybe, that might be then something more. But it tends to be, looking at the patient holistically and, would they be a good candidate? There's a better options like tacrolimus, especially topical tacrolimus, is a great option for, as instead of like an oral immunosuppressant, but like a topical immunosuppressant. The biologics tend to be a little bit more targeted, so you have less side effects with those. But really, last line, like, my life is in shambles for those types of meds.
Thank you.
Yeah. It seems like such a simple problem, like, oh, hair loss, like everyone's going to have it, but it affects so many people, and people's whole lives can be changed, or their perceptions of things can be changed. Skylar.
I know that a lot of people come with like obviously like receding or like hair loss back here and everything, but in the terms of just like a receding hairline, do you still kind of recommend the same like treatment for the hair loss?
So first and foremost, great history and physical. If anyone ever asks you in school or, residency, like, what do you do first? The answer out of your mouth should always be history, a good history physical, which I think I kind of touched upon it a little bit about like Caribbean students, for whatever reason, and from my own experience and from other people's experience, like attendings, like Caribbean students' physicals and histories are like spectacular. So we are taught so well to like good history, good physical, and it's a different type of experience, maybe not as like, we didn't go to like GW with like all these resources, or Harvard Medical School, but we learn to do medicine in different ways. So a good history physical always. Um, then from that, you can kind of say, okay, what are my differentials? What am I dealing with here? Is it a telogen fluvium? Like, pull on their hair. Absolutely. Look it under the microscope and see like, hey, listen, it's, telogen effluvium. Like, you can see the clubbing of the root. You can see the cortex, like that waxy part of the follicle is missing. And you can just give them reassurance, which some people don't like. But I've had a couple patients with that, and hey, their hair comes back. Receding hairline, if you said, hey, listen, this is what's happening, you're just having a receding hairline. And ultimately, that's just age. And again, that's a whole nother differential, just age related, hair loss. you can do certain things like a finasteride, let's say for a woman with receding hair, finasteride at that point in time, is it going to do much? No. But maybe like that minoxidil, that vasodilator, you bring more blood flow to the area, more nutrient-rich blood to the area to help stimulate those follicles might help, if not help slow down the progression. Um, and then also, which again, for those who are still on the fence about family medicine, um, that's what makes family medicine so great. Like you're looking at things not just from a disease state, but the patient holistically, right? Like what are their barriers of health? You know, health isn't just the absence of disease, but the emotional, mental, and physical well-being. And I think family medicine does such a good job, Dakota, in doing all that. Um, so are they stressed, right? Are they eating fast food 5 days a week? Are they not getting enough biotin? Maybe giving them a biotin supplement or a B complex, or even just certain little retinoid cream, not creams, um, just different topical things that you can do for them as well, right? To kind of help them. So it really is just individualized, but at the same time too, yes, certain meds like those can be used almost like in a blanket thing, like bringing blood flow to the area is always great, or even just like a manual light massage to the head. So great history physical, figure out what's going on, and then you can pull out, okay, no one's ever going to die by having too much biotin, right? Like their nails are going to look great, their hair is going to look great, their skin's going to glow, they're going to say, doc, you're amazing. Like I got three people's numbers yesterday, like look at this skin, right? So um yeah, you can kind of pull those out of your toolbox, but getting down to the root cause of it is always the most important thing.
Thank you.
Yeah, of course. Yes, Dakota.
This is kind of like a three-part question. So,
Oh, I'm ready.
first, like, do any of these hair loss diagnoses have like a racial predisposition? And does this racial predisposition have anything to do with like the actual structure of the hair follicle between different races? And then the third part is, do like any racial factors influence treatment in any of these?
Wow. Wonderful question. By no means am I like an expert in this category. So, um, but yes. So number one, the first one, what was your first question? I just want to go down so I can do the bullet point.
Do any of these diagnoses have like a racial predisposition? Like, is one of the more common in
Yes.
Caucasians, African Americans, etc.?
So I'm pretty sure alopecia areata tends to be a little bit more common in individuals of color. Same thing with tinea capitis, and the tinea capitis actually is, if you look at it, it tends to be because of other extenuating factors, right? Like it's not just because, individuals of color are just prone to dermatophytes. No, it's the other socioeconomic reasons that contribute to those individuals having an increased risk of this dermatophyte infection. And if you look at certain autoimmune diseases, right, like they tend to also have a racial component. And so that's why the alopecia areata, the ones that tend to have more of like an autoimmune disease component, tends to also affect individuals of color. Like let's say same thing, like Hashimoto's has more of a prevalence for a certain type of racial group, and so celiac disease has a certain type of higher prevalence in a different type of racial group. So you do have like those common like commonalities in between different races. Well, increased risk for like certain diseases like alopecia areata, I believe, in individuals of color. I know you said about like seeking treatment, right? Obviously, there is a bias in medicine towards individuals of color, which there shouldn't be. But it also tends to be in seeking treatment, right? Like those with the means can unfortunately seek treatment. Maybe, they don't have childcare. Maybe that they're working three jobs just to, they're a single parent. Like they don't have time to get this stuff done. While meanwhile, some, retiree who was a lawyer in a big shot career, like they're going to have, you're going to see those people more in clinic or in your office than compared to like the single mom who's, trying to struggle to make ends meet, unfortunately. So again, there is tends to be not just like a racial bias, but a demographic bias in that sort. And then what was I think that was the third point. What was the second point?
Like, does I guess like the structure of the hair have anything to do with hair loss, like people with curly hair, coarse hair, et cetera, et cetera?
So that I'm not too sure. I would have to go back and look because with like you said, like the different types of hair, the follicle shape, the root of the hair follicle is differently shaped. And so I would have to look. I'm not too sure.
I think
Thank you so
going
much.
off of that is really important to note that. So a lot of this presentation was obviously based off of prior research, and research is often done on white males. So there might not be a lot of data behind what you are asking. And I think that this is just a good time to keep in mind that it is really important to research both genders, all people, because we could have the answers to this.
Absolutely. And that's really like especially in like skin and hair, like 100% because like most of the research is done in, like you said, like white males. So finding both, especially if you have a skin condition or a rash, like looking at it in, both light skinned and dark skin complexions, like is going to make you a better physician. Mona.
Thank you, guys.
Hi, and thank you for your wonderful presentation. It's pretty interesting to me. I was wondering, when you were doing your research, did you come up with experimental hair clonings? Did you see anything like that? Because I think they're doing some hair cloning in Turkey, and I was wondering if do you have any, I don't know, have you done any research about that, or have you
I
done anything about
I
that?
have not. Has anyone have you seen anything? No, I have not. That's a great thing. Now you're gonna give me some homework to read about later. So thank you for that. Um, but have you guys seen anything? No.
I didn't even know that that was a thing. That's
No, me neither. You're
fascinating.
surprising me. Yeah.
Yeah, I've heard in the Middle East countries they are into that, like especially
Okay.
Turkey, I heard is doing hair cloning. I was just wondering, like, what would be the regulations or what are the ethical considerations that US is not, moving forward or progressing as Turkey is or other
Yeah.
countries.
That I would have to look into all of that. That, like I said, I didn't even know that that was a thing. So thank you for
Sure, of
enlightening me on that.
course.
Harleen.
Hi. Thank you so much for such an educational presentation, Hannah, because during my rotations as well, I've been seeing a lot of patients come in with hair loss issues as well. So thank you. I just had a question. So I know that PRP has been gaining a lot of traction in recent years, but I remember reading a paper maybe like a yearish ago, which said that there's not much of a difference that at that point, at least, that they noticed with the use of PRP. So I just wanted to know if, in your opinion, what kind of patient populations they seem to benefit from the use of PRP the most.
Yeah. So there is a lot of conflicting research on that. Even like, there's even not just for like the injections for the hair, but also into like joints and other things as well. There's a lot of conflicting, hey, does this work? Does this not work? You can like, I think it was some NFL football player last year or 2 years ago. I think it was like Aaron Rodgers or something, like snapped his Achilles and had like the speedy recovery, and people were like, hey, what was this? What happened? And he swore by, that it was these injections like of his own plasma into the Achilles tendon that helped him recover. For him, anecdotally, sure, it worked. Um, it really does depend again on your population of your patient. Um, what I have seen, again, anecdotally, is that individuals that benefit from that the most tend to be younger, tend to be affected with like the alopecia areata or just even like the thinning. I'm sorry, not the areata, like a telogen effluvium or just like a diffuse thinning of the hair where it just gets really light patchy and like people just start pulling out their hairs. I've seen it actually work the most in young females. Um, as you start to age, as you start to your hair follicles start to like there's a peak, right? So men, I think the peak of the diameter of the hair follicles like the mid 20s, and I think females is like 30, low 30s is when the hair width and the follicles at its biggest length. After that, it starts to shrink, the blood supply starts to shrink, everything starts to kind of age and die. So as you're starting to have that progress, like you're going to have a less of success in a 65-year-old female than you're going to have in a 20-year-old female. Um, but again, it just boils down to really your patient, how willing they are going to want it. Some people don't want the injections. Other people say, hey, listen, like I'm willing to do it. Other people are like, no, I hear it's painful. And so for some people, it is. Other people tend to tolerate it better. So again, it's not like a blanket fits all, but some patients, like if they get 2% of their hair back, they're happy with it, or they just want to stop the progression of it. So it really just like patient based, but it really I've seen it anecdotally work more in like young females, but it really just depends on the group because there are a lot of conflicting studies that say this stuff doesn't even work. So
Thank you.
yeah. So I think, some of us might have seen people in the clinic already with these complaints. Has anyone felt like it tends to be a certain demographic over another? What has everyone's experience been with this? Because it affects everybody, What's kind of like the patient group that you've guys seen with coming in with hair loss complaints?
When I saw it actually in family medicine, it was a really young female.
Yeah. And it's funny because that would be probably the answer that I would have given to most patients that I've seen are usually at least 40 or younger and female coming in. But if you look at the statistics and you look at the number, hair loss affects actually men more than females. And that gets into, especially young men don't want to go see the doctor, sure, but they're also not as willing to divulge, hey, that this is bothering me. And that kind of ties into the mental health component as well. So really establishing such good rapport with your patient is so important, right? Like they're not just the disease, they're not just their chief complaint, but they're a person. And the more you build that transference and counter transference with your patient, the more that people are going to feel obligated or at least open enough to talk to you about this because it can be a pretty stigmatizing topic for some patients. Does anyone have any other questions or any other like stories or anything they want to share about hair loss?
I have a question. Being that you're a family medicine physician and you use these like drugs pretty frequently, I think that beta blockers and ACE inhibitors like are somewhat notorious for causing hair loss. What is the best way for you to like I guess manage expectations for a patient on those who comes in complaining of now they're having this side effect?
Sure. So absolutely, right? Like you can always, first off, when I start patients on drugs, I always let them know, hey, listen, like obviously I can give you a pill that's going to do A, but it might cause B, C, D as well, right? And so setting expectations from the get-go, I think is always important with patients, especially if you're in a specialty where you're managing many different drugs or starting patients on drugs. Mechanistically, like, right, like when you're decreasing blood supply to an area that is constantly in mitosis, constantly growing, and you constrict that blood supply, that area is no longer getting the nutrients that it needs to grow. So, it can happen, right? People can start to complain, hey, that my hair is not as thick as it once was, or it's more brittle, or it's thinning out. So starting with, hey, I know that this is distressing and I absolutely hear you, and being completely sympathetic, like empathetic with patients is step number one for sure. And then leveling with them and saying, okay, well, you were in the hospital last week because you had a heart attack because you didn't see a doctor for 20 years. And now we're getting better control of your blood pressure, but your hair is starting to thin. What's more important to you right now, right? Like, and leveling with patients. Like, if they say, absolutely, doc, I'd rather be dead than like have no hair, then I'm going to start to, number one, document everything, right? Because this is unfortunately the world we live in where people are so litigious. But um, you're their doctor. And that's another thing that I say to patients too. Like, you're in charge here. You're the captain of this ship. I'm just here to help you navigate the water. If you tell me you want to go here, I'm not going to sit here and argue with you and tell you, no, we should go over here. Right. So if that patient who in my story was like with the heart attack, if they'd rather die than lose their hair, I might change their meds. Like, we do have other tools in the toolbox, to use maybe instead of like having them on lisinopril or a beta blocker, because those tend to be a little bit more notorious for the hair loss, like maybe switching them over to like spironolactone or Paralone or something else that can kind of manage their blood pressure. And it's really just kind of, again, like what's most important to you, to the patient, and just leveling with them. And if you do that with patients, they are absolutely going to love you. Getting down, knowing, like not knowing what they want, but like going in with what do you want, what's important to your health. Because people, right? People go to the doctor, they always complain, oh, my doctor talked down to me, my doctor didn't hear me, my doctor didn't do this, right? Like I went in and I wanted to talk about this, but my doctor like harped on my cholesterol for 20 minutes and left the room. That's not a good way of practicing medicine, but making sure it's important to your patient. So if the patient would rather not have a heart attack again, then just saying, hey, listen, let's, build up on your supplements. Let's do some more vitamin B complexes. Let's, change your diet. What are you eating? Like have some biotin, maybe do like a little infrared scalp helmets that kind of help keep like the heat and stimulate the scalp with like heat instead. There's other ways of going about it too. You definitely have more like tools in your toolbox kind of thing. But definitely know what's important to your patient first.
Thank you.
Yeah, of course. This was an absolute wonderful topic. Like you said, multi-specialty topic. So this is good. Thank you, Hannah.
Thank you for joining us, Tyler. It was really
My
nice to
pleasure.
have you here to answer all these questions because I would not have been able to answer them as well as you did.
No,